Interfaith Works here in Syracuse and did a presentation on this. I received his name and contact information from Dean Gail Wolding and contacted him, and he was very gracious to agree to be with us today. David holds a PhD and an MPH, a Master's of Public Health from Tulane University School of Public Health and Tropical Medicine. He is an environmental epidemiologist with expertise in large data analysis, multi-level modeling, spatial statistics, geographic information systems, and study design. I think I might understand one of those. His content expertise lies broadly in global health with specific expertise in mosquito-borne illnesses, health, and sanitation. If you'd like to find out more about him, there's lots more. If you simply Google his name, he's associated with the University of Syracuse, here in Syracuse, where I happen to be today. So Dr. Larsen, we welcome you. I'm delighted and thankful that you're with us for this conversation. We will work to hold it to 1 hour and out of respect for your time and others. And I'm going to turn this over momentarily to Julie Grindle for some instructions.
Good afternoon, everyone. For those of you who have been on the Bishops Forum before, we typically just say if you'd like to make a comment to put your name in the chat. But today, as you can see, there are many, many of us, which is wonderful. So we're going to ask if you do have a question for Dr. Larsen, please don't just put your name, but please go ahead and ask your question in the chat, and we can direct him to those questions, very much like my husband took when he led the PPP discussion. So we think that will be a better use of our time today. And also just a reminder, if you came in after Norma's comment, this is being recorded. So if you do not want your face, your beautiful face on the recording, just take yourself off of video, please. We are providing that for those who could not be with us this afternoon. With that, Bishop, I send it back to you, and I will be monitoring the chat.
Thank you, Julie. David, I will turn it over to you to take over at this point in time.
Thank you, Bishop, for for hosting me here. So I'll give a little bit of background on my experience and expertise. I've spent the last 10 to 15 years of my career fighting malaria in Zambia and other parts of sub-Saharan Africa, also with some deviances in terms of other disease systems. And my work there has been ranging from trying to design surveillance systems to track and respond to malaria, as well as controlling and then even eliminating transmission from geographic areas. As the coronavirus kind of took over 2020, I began to realize that many of the same issues that I've spent my career fighting with malaria are present here with our response, our country's response to coronavirus. And those are challenges with diagnostic tests, uncertainties around policies such as masks, and then there's other challenges that I won't go into. And then the challenges around the surveillance system, certainly tracking the confirmed cases and the absent or asymptomatic cases. So I reached out to the Interfaith Works on masks. That was the first goal. Is I had gone through the literature like any scientist should, and I identified what the state of the science is around wearing masks. And I was a little bit frustrated that the CDC had not adopted this in terms of their approach to coronavirus. That quickly, CDC did come around. They've now adopted that intervention as potentially being helpful. And so now I'm shifting my work in coronavirus to surveillance. We're trying to spin up a surveillance platform for Upstate New York based on wastewater with some colleagues from ESF and Upstate. And that'll hopefully identify areas as coronavirus absent or free, which would be a pretty big piece of news if we can establish that. So we've got a lot of science and focus on that. But I'm made myself available to Interfaith Works to answer questions. I can take any questions here, and just as a kind of a public service, I understand the importance of faith and the influence that faith has on individuals. I worked with faith leaders in Zambia around, sanitation, malaria, other aspects, and I've seen firsthand the potential for public health progress when incorporating faith leaders into the dialogue. And so I wanted to make sure that you were empowered with understanding and knowledge such that you can help those that you serve. So with that, I guess that's my introduction, and I can take any questions you have or talk about coronavirus in general if you'd like.
Dr. Larsen, this is Julie. Before the chat starts filling up, and those of you who are on this, go ahead and start asking your questions, but we are definitely hearing our pastors asking how can they make their churches safe for their congregations when they return, whenever that is, right? And how will we be able to sing, and we'll be able to share anything that is common in the sacraments, communion, baptism, anything like that. So I'll start with that. And now the second I said that, of course, there are things in the chat. So if you could just start with that, and then I will be quiet and take you over into the chat box.
Yeah. So when we talk about the safety of public gatherings, or the safety in socialization, I guess, in broad terms, you have for infectious disease, you have different types of contacts with other people. And you have, depending on the way that the disease is transmitted, you have probability of transmission, right? For respiratory illnesses like coronavirus, like influenza, we can divide our contacts into two separate categories. We have intimate contacts and we have casual contacts. Now, an intimate contact is somebody that we would hug or shake hands with. We would have a more physical interaction, not necessarily physical intimacy, that's different. But that intimacy that we enjoy with other people that we care about and that we love, right? Casual contacts are those that we just bump into on the street, perhaps. We walk past them in the grocery store. We see them as we're walking our dog. We don't touch them, and they don't touch us, and whatnot. Now, for this respiratory virus, for coronavirus, and for influenza, the intimate contacts are the primary drivers of the transmission, right? So these are where the exchange of the viruses between people, based on handshakes, hugging, maybe even a kiss, proximity to each other, talking closely with each other. That's the primary driver of transmission, from what it appears right now. Now, churches and places of worship are friendly places. There's a lot of love within churches, and so from an epidemiologist perspective, worship gatherings, church gatherings, they scare me as places that can facilitate a lot of transmission very quickly. One of the key aspects of coronavirus that makes it difficult to control is that it's not always lethal. So if you can compare, we've had epidemics of Ebola in Western Africa and the DRC, the Democratic Republic of the Congo, over the last few years. And you can compare the Ebola control to coronavirus control. Now, Ebola killed maybe 30 to 50% of the people it infected. Extremely scary. From an epidemiologist standpoint, there was not really concern about Ebola transmitting within the United States. We felt like we could control it based on controlling anybody that potentially arrived. And we had people that arrived from West Africa, from Sierra Leone and Liberia, that brought Ebola back to our continent, but it didn't spread from there. I think we had one case where it spread to a nurse, and after that, it didn't go. One of the reasons that Ebola is not as scary for epidemiologists is because it is always, not always, but well, it's always severe. It always leads to severe disease. Now, coronavirus does not. An estimate, I think, is maybe 20% of infections leads to a more severe disease that might require hospitalization, and then there's a substantial amount of, it's not known how much yet, and but there's a substantial amount of pre-symptomatic transmission, so people are transmitting before they're ill, and then even asymptomatic, so people could have the infection but really not feel sick at all. And so that makes it difficult to identify where those cases are, where those infections are. And then from a church standpoint, you don't necessarily know, just because everybody appears healthy, you don't necessarily know that nobody is infected and that it's a safe space to gather and to enjoy each other.
So we have quite a few questions in that space that are impacting, right? For instance, is there a safe group size within a room? And can we sing if we are in a group size that is distanced, if we are wearing a mask, for instance? So I'll ask those questions because I see those questions sort of scattered through the chat. So let's start with that, and then I'll get to some more specific questions from there. But I think those are kind of the two main questions, because it sounds like you answered Deb's question, which is what was unique about it, right? What's unique about it is we can't tell that people are sick sometimes.
Yeah, I think, in that regard, that makes it different from Ebola. That's not necessarily different from influenza. And there's been influenza pandemics over the last few years. Coronavirus is much more deadly than influenza, so that makes it different from influenza. Every virus is unique, and they all have these idiosyncrasies and nuances to them that make them challenging. So when we talk about our social circles and our contact circles, because we have our intimate contacts, right? That's our primary households. So right now in the say we're practicing very strict social distancing, we have people that live within our house would be our intimate contacts, and then everybody else outside is casual at this point. Every time we venture into a casual space, we run a risk of contracting coronavirus, right? It's less risky than the intimate contacts within the house transmission, right? But we still run that risk at the grocery store, the post office, or whatnot. Our pre-coronavirus worship extends that intimacy from just our household. And so very excited for the Frozen book. And so the pre-coronavirus, our places of worship would extend our contact network, our intimate contact network, to include those people that we see at church and that we would shake their hands and hug and be very happy to see them. Post-coronavirus, right, with coronavirus, to try to stay safe from coronavirus, we can try to reduce our church activities or our social activities. We try to reduce those to casual contact. And how do we do that? It's hard. We're social beings. We need physical touch. We need emotional support. All these things. And so that's potentially a big challenge. Singing is scary also. I think most, if not all, are aware of the outbreak in the church in California, where they had a choir practice and coronavirus was transmitted throughout the congregation, or throughout the singers. I think it was a chorus or a choir, and there were a number of infections and even deaths with that. And the reason is, as you project your voice, you also project your droplets. And so that's just spreads the coronavirus from you. With masks, masks are not 100% effective at blocking virus particles. And so even the N95 respirators, they filter 95%. That's why they're an N95. They filter 95% of the particles that are the size of coronavirus, which is like 0.2 microns, really, really tiny. Now with singing, or with droplets, those tiny microns are typically attached to larger molecules of spit and whatnot, and so that would hopefully get caught in the mask. But that is a risk that Yeah, so that's something that would be risky.
Could, if, if people were socially distanced within a sanctuary in their family groups, would that be a safer way to sing behind their masks?
I don't.
I mean, we are grasping at straws here.
I know, and to be frank, the conversation reminds me of being a teenager and asking where the limit is with the law of chastity.
Exactly.
You know, how far can you go without breaking the law of chastity?
Yep.
Maybe Bishop John can give us some insight into that for those of us that want to know, because I still don't know. Right.
Okay.
And I think what scares me about is the age and the comorbidities, and so I get really nervous. You know, my congregation is older than the population of Syracuse on average, and I would think that even with socially distant family groups and masks, you would still get some transmission. That would be my suspicion. You would still get some transmission of coronavirus or other illnesses.
Thank you. I'd like to look at some of the other comments in the chat, since there are so many. The bishop asks, what needs to be done from your perspective regarding our buildings and the distribution of the Eucharist? So I'm imagining, for instance, if a church decided to hold 2 or 3 services in order to limit the amount of people within the building, probably a cleaning needs to happen between services. And then certainly distribution of Eucharist, what is that even possible?
So Eucharist is I forget my ignorance. Is it a common cup or is it a separate cup?
It is all over the place.
All differs. Because I would be much more comfortable with separate cups. I think a common cup would be one that would invite transmission of disease. I know. So that's the first thing is separate out the cups and not pass the same cup around. You know, the good hand hygiene would be required, and then when you do give it out, you would have you know, the idea of separating into groups is good to try to reduce that. Oof. It's another challenging one because, you know, the epidemiologist in me says no, can it wait? And then I understand how important it is for people to partake. And so I would try, you need extremely good hand hygiene. The person offering, if it's the bishop or whomever is offering the Eucharist, would need to be sure that they are practicing good social distancing themselves. They would need would probably want a mask on, definitely. And then as people come through to take it, you know, social distancing and whatnot. My big fear in the Eucharist is that the bishop has a viral infection and then transmits it to the people taking it. That's where I think the transmission would occur most in this scenario. With the people going through, I think with good social distancing and masking, it could be treated similar to a grocery store and the way that the grocery stores are handling things. And I guess that begs the question if this is an essential service, and you know, I consider faith essential. So I think that I would take cues from the way that grocery store checkers are operating. The ideal, although it puts the bishop or the priest at risk, would be to distribute to houses Well, I don't know if that's ideal. That's one way to try to mitigate. Because when you have, there is evidence that the coronavirus does have some aerosol transmissions. What that means is you breathe out or you expel this droplet, spit molecule. And as the spit hangs in the air, the spit evaporates over time, right? So it kind of goes away, and then you have the virus left over, and that virus can survive for a few hours. And so there is that type of transmission. Well, that's probably less likely than the other types of transmission. And so the question would be, for people coming through the church, how that happens and how that goes. So you want people wearing masks, but then you got to eat. So you got to take the mask off, which makes sense. So that's a challenging one as well. I don't have solutions for you. I just relate it back to, where's the line? And the further from that line you can stay, the safer you'll be. And as you approach the line, it does entail some risk.
So we've got some questions about group size. Of course, we have churches whose rooms are much bigger than others, right? Who can have more people in them and still be socially distanced. So if you can sort of give us some guidance on that. Yeah. And also, we're getting sort of conflicting reports about how this virus is. It sounds like it's dangerous for older adults, and yet we are now hearing its impact on younger people. So, maybe that's really a problem for us too, right?
All right, so on group size, when we think about groups and social networks, everybody carries with them their social network, right? So I have 4 kids and my wife, and we're our family of 6, so we're this little unit. And then I have my work, right? And so I bring what's out here with work back into my house. And then my wife, without coronavirus, she'd go to the gym and visit friends and do her church service. And so she brings all that stuff into the house. Our kids go to school and they bring all that stuff out into the house. Now, social distance, we try to get rid of all this, and we just have the
Dad, you got rid of our things. Dad, you got rid of our things.
I got a what?
You got rid of our things.
You got rid of all your things?
Yes. Just went in the pool book and there's a fun book.
Awesome. Thanks, baby. Sorry. And so with social distancing, right, we reduce all of that to our household unit. And so we have that intimate contact within our household unit. Now, every time we venture out of that house, we carries with it a probability of bringing that in. And our church service group our church worship is going to be a more intimate contact. So that's, bringing this whole group. So when you think about my family unit and our ventures out of the house, we go to the grocery store, we go outside to get some sunlight and some exercise, different things. Now, if I team up with another family at church, then then we have that intimate group. So we got basically become one unit of potential transmission, one dynamic. And then we have people going out and coming in for random purposes, right? So grocery store, post office, and whatnot, or essential workers that it's not so random. They have their essential work, and then that carries with it the risk. So each of those excursions from that closed network carries with it a probability of bringing back coronavirus to the closed network. And then you have the church service. So the bigger the church service, right, the more number of probabilities there are. And so even though the probability of bringing back coronavirus is low for a single person, if you have 100 people, say it's 1 in 1,000, then you're up to 1 in 10, because you have 100 people going out, and then each of them, you have the cumulative probability of 1 in 10. And so hopefully that's clear. But the larger congregations do carry that larger risk, because once the virus gets within that social network, the probability of transmission is pretty high within those intimate contacts. And so larger congregations are higher risk. You know, I would, at the university, we're talking about this in terms of class size. You know, and my thoughts are, you know, limit the class size to about 25 students going forward. Then I would think that the congregations, that might make more sense as well. About that 20 to 25 would make sense.
Per service?
Per closed, well, yeah, I guess, yeah. That's that low. I'm sorry, that's low.
For some it is.
Yeah, no,
Wow.
it's so so we have our intimate contacts within our house, right? And what church service does, and when it's a large church service, it takes that high risk of transmission within our intimate contacts and it makes it a high probable event. And so they're called super spreader events, where you have a lot of people who are in a lot of contact with each other, and if you get one infection into there, then you have quite a big strong dispersion of that. This happened with the soccer games in Europe. This happened with conferences here in the United States, professional conferences. It's happened in churches as well. And so these larger gatherings, I would think that they would need to be reduced in frequency, if not altogether eliminated, until we're really on top of knowing that we don't have coronavirus transmission in this area. And hopefully we can get there.
And in your opinion, when do you see that happening? Like if our pastors are looking ahead through the summer, when might they be even thinking about opening their doors again, realistically, even to small groups?
Well, we know it's not going to be before May 15th, I believe. So we know that. And I believe that the cases in Onondaga County have increased over the last few days. When we see cases today, so cases today are reflective of transmission weeks ago, maybe 1 to 2 weeks ago. Deaths today are reflective of transmission 4 to 6 weeks ago. So we have this delay, right? So what we see now is a result of transmission that happened in the past, and what we see in the future, and it makes it very difficult to understand what's going on in the future. Now, the numbers to watch, in addition to the cases, would be to look at the numbers of community spread cases, and I think those are ticking up from Ryan McMahon's press conference, his press briefing in Onondaga. Positive signs that I've seen so far is finally they're starting to talk about contact tracing, right? And this is 2 months too late. With hindsight, you know, I think at least it's a month late without hindsight, 2 months too late with hindsight. But the contact tracing will help. The way to defeat this infectious disease, as we can see that's happened in New Zealand, in Taiwan, South Korea, is aggressive contact tracing and isolation. So you get more tests out, so you're able to test all the suspected cases. You put those people in isolation who are infected, so they can't infect anybody else. And then you go look for people who they had contact with, who they may have infected before you got to them with the test. And then you test those contacts, and then you put those in isolation as required. And that works. And it looks like it works really well with this. And so if that system can get up and running and go, and as long as the people are willing to endure social distancing a little bit longer, right? Social distancing is never meant to be the cure. It's never meant to be the intervention to fix coronavirus. It's meant to buy us time so that we can get the test, trace, and isolate interventions up and going, the contact tracing and the isolations. As long as we can endure this a bit longer, then we can give that contact tracing time to work, and then we could actually be back to normal. You know, I'm typically optimistic, but 3 to 4 months from now, we could potentially have extremely low transmission of coronavirus and a better knowledge of where it is and what areas are affected and what areas are not. So I'm starting to see the systems come into place that, that have not been here. And the technology's catching up in terms of the diagnostics. We're starting to get rapid tests, and those are very helpful. And the question, I think, the big question will be whether the people can endure social distancing a little bit longer, because I think we need it a little bit longer. And then how cooperative the people will be with isolation and contact tracing, because it does depend on the buy-in from the community. If the community does not cooperate, then it doesn't work. So.
And so that's really helpful, actually. You just said 3 to 4 months. It sounds like if you believe that the contact tracing can get going and the testing can get going, and we've got some questions in the chat about the different kinds of tests, right? We have not just the test for COVID-19, but also the antibody tests. Do we know that if you are tested positive for the antibodies, do we know that you are then not going to contract the virus again?
No, this has been a frustrating thing to observe in the news media, with the idea of getting an infection certificate, so to speak, that you've been infected, that you're safe. So there's a value, a probability that you can calculate called the positive predictive value, and that's the probability that your positive result is actually true. And that is extremely low when prevalence is low. It's dependent on the prevalence of the condition that you're testing for. So upstate New York, the New York State estimated 3% prevalence of transmission up here, or lower than that, changes, and was a bit biased. At that level, it'd be like if you test positive for this antibody test, it'd be like flipping a coin on whether that test is accurate or if it's false. So antibody tests cannot be relied on at a personal level as a certificate of infection. Now, if you get infected, are you then immune? All the science right now points to some level of immunity following infection. It's not known yet what level that immunity is, or how robust that immunity is, and how long it lasts. But all the preliminary science around this, and it's not an answered question, it's still questions about this. The preliminary science does suggest that once you have been infected, that you're relatively safe from COVID-19.
And would you be comfortable if the contact tracing could get into place if we did not yet have a vaccine in place? Or do you see that on the horizon?
Yeah. I'm very optimistic around contact tracing, the trace, test, and isolate. I think that was the game plan. That's the way to handle infectious disease. That's what you do, and it's been known for years and years that this is how we do it. And yeah, if the surveillance system is in place and the contact tracing is in place, I think we can get back to a normal, quite normal. There's actually, sorry. I think we can get back to quite normal without a vaccine. I think at the same time, like the state fair and some of these really big events would probably not want to have those. Those make contact tracing very difficult. If you have complete elimination, right? It's like New Zealand, they could have state fair because they've got it under control, but we don't.
So what do you say to pastors who are in parts of our state where there are very low numbers of cases, who say, like, we could open up tomorrow, right? Why are we even closed down? Versus Onondaga County, Erie County, the Albany, right, the capital region. I think there's some frustration that they're feeling, right? How do you react to that? So let me start there. I jumped to the bottom of the chat, y'all. Sorry about that, but I wanted to do that first to make sure I got to that question.
Yeah, that's a very good question. So the social distancing we have right now is very broad, and it's basically a concession that we don't know where transmission is occurring, and we don't know. We don't have a handle on controlling this, and so let's lock down the entire state with a stay-at-home order, and that's a very broad brushstroke, and it's not a one-size-fit-all intervention. Ideally, for some of these counties, rural counties will have. So when you think about the epicenter of the epidemic in New York City, why did we see such a big outbreak in New York City? And it all has to do with the amount of travel in and out of New York City. And so we had travel from Italy, as well as China, bringing the infection into New York City at multiple points. And then a social contact structure with mass transit and other factors that facilitate the spread of this within the city. Now, outside of that, right, all the other counties are going to see their probability of transmission relative to how much connection they have to New York City. And so then you get that Onondaga, Buffalo, Albany, Ithaca, all these bigger, Rochester, all these bigger metropolitan areas because of the travel back and forth. That's just more travel, more people, more events with a potentially a low probability of transmission. Just more events means higher probability. And so then you have these centers. Now the rural counties, what you'll see is it'll be delayed, and then it'll look very sporadic. And so you might get a place with just a few cases here, right, in one little township, and then this village had a number of cases, and that's just based on people traveling and bringing the virus with them as they go. And so with those probabilities, the probability is low at this point in time for these churches to open up, the probability of transmission. But the probability is not zero, and it's dependent on how much travel between it's dependent on the transmission locally within the community, as well as how much connection to areas with established transmission. So how connected, and I think you mentioned Herkimer County, so how much transmission is local within Herkimer County, and then how well connected is Herkimer County to these areas with higher transmission. And the more well connected they are, then the higher probability of transmission. Now that goes for communities, but then you can also go into individuals. An individual's risk of coronavirus is a function of both the transmission level within their community and also the connectedness they have with that community, and then to communities where transmission is higher. So the more that they travel, the higher risk they're going to be. What we see with this virus and others is those that can travel are typically a little bit wealthier, so they actually act as the carriers of the virus back to their communities. Once it arrives in the communities, and it gets into lower income households with more crowding and less access to healthcare, and you have bigger burdens in the lower income houses or lower income households. So I very much understand the frustration of folks in areas like Herkimer County. My family's all out west and are frustrated to the max. Right? I've got friends on Facebook posting that that this is not worth it, and I'm very glad that they have not seen the death and disease that's been observed and witnessed in New York City. But if we stop social distancing now, right, that we carry the risk of bringing those infections in. And so as a person in Onondaga County, and this would go for wherever I lived, my satisfaction with my personal risk is going to be influenced heavily on what I see from the county health department and the ability of the county health department to get at those chains of transmission, because it will arrive, right? Coronavirus will come into all these counties and all these villages, all these townships. We've seen that from influenza throughout the decades. And so when it does arrive, can the county health department, does it have the capacity to jump on it and interrupt transmission so that it doesn't go through the entire community and affect everybody? So,
Thank you. I have some sort of specific questions. If churches, especially as the weather gets nicer, wanted to hold worship outside, where they could perhaps physically distance a little bit easier because they don't have walls to deal with, Would you see that as a possibility of people outside of their cars as opposed to a, kind of drive-up worship scenario, which some churches are already employing? Is it safer to be outside? We do tend to live in windy areas here in upstate New York. So I don't know if that plays into it. So if you could speak to that.
Yeah, so two things. The wind is interesting that you bring that up, and then the outside. So ultraviolet light will kill this virus. It will make it non-tenable. And so there is some science to suggest that outdoors is safer than indoors. And so what that means is if you have the virus on a surface, it won't survive as long outside as it would inside. And if you have the virus hanging out in the air, it won't survive as long outside as it would inside because of that ultraviolet light. Now the wind, that's an interesting thing to bring up. With one of the interesting case reports out of, I think, South Korea showed transmission within a restaurant, and the transmission occurred along the path that the air conditioner was flowing. So if the air conditioner is flowing this way, each of the tables in line with the air conditioner is where they saw cases, and then the tables that were not in line with the air conditioner, because they had the walls here, and then they had different air conditioners, right? So one going this way, one going that way. So the tables along the bottom where there's no air conditioner didn't have coronavirus transmission, and so wind does, air movement does matter. I think with drive-through, you just have that single interaction. So how do you protect the priest or the bishop or whomever's doing the service, and then how do you protect the person receiving as well? So
Yes, there was a question. There is ultraviolet light on cloudy days. I've always been told that, right?
yeah, you can get sunburned on a cloudy day.
Right. Yeah, that's what I thought. I've got a couple of very specific questions. Handling offering from an offering plate, so cash, things like that. Is that an issue?
Yeah, wash your hands. Yeah.
So you should just handle it you need to.
Yeah, so whenever you're in public and touching anything, right, you should try to not touch your face, and then wash your hands as frequently as possible, and then definitely before you come back home and stuff.
And we had a suggestion from a communion standpoint, because we typically, even if we're using individual cups, right, that's still the pastor is involved in providing that somehow, right, or the bread or whatever. But there are individually wrapped bread and wine that could be used that's already, is that something that you might recommend? That's
the environmentalist in me is.
I know, yeah,
right.
But
so
is
little
it safer,
sachets
I guess,
or
is
things.
the question.
Yeah. So what you have, the risk of transmission is that the virus is on the pastor's hands, gets transferred to the Eucharist, and then that gets transferred to the person taking it. So I think if you have prepackaged stuff, I'd worry about the packaging as well. I would definitely want the person preparing to have a mask and to wash hands, to be very thorough with their hand hygiene, and very cognizant of any potential symptoms, fevers or upset stomachs or anything.
So after we talked about the wind, people are now very concerned about their air conditioning systems and the fans in their churches. It sounds like they should be.
Yeah, so one of the reasons why did coronavirus spread so crazy on a cruise ship, and one of the reasons is the air circulation. And so ideally, if you have a self-contained air system within a room, that room would be fine. But if you have air systems that circulate in entire rooms, then it does create problems.
Okay. We've got a question again to keep the clergy safe, but also in their as they are in physical communication with their congregants, should they be being tested on a regular basis, right? They can't necessarily make their, or do their congregants need to be having their temperature taken as they walk through the doors? So the first question is, right, should a clergy be being tested maybe even on a weekly basis in some way, whether it's for antibodies or for the virus itself? And should there be any kind of testing for fever before they come in?
Yeah, I'd like to see us get to a point where all essential workers, all public facing essential workers are getting regular testing. That would be good. I would not want antibody testing. I would want active infection testing. Antibody testing on an individual level is not very useful, but active infection testing is. The other question around, what was the other question?
Oh gosh, you caught me because, should we take the temperature of our congregants before?
Oh, temperature screening.
Yep.
Yeah, so this is one that I've thought about with the university, whether this should be something. Temperature appears to be, well, first off, a fever is very non-specific, right? So human immune systems, we develop fevers to fight basically everything. For coronavirus, temperature appears to be the most common symptom. And so as a screening tool, a fever check is, I think, going to be useful. Whether that could, I think, well, let me hedge that a little. It could be useful. Whether that is actually helpful, that is yet to be seen. I think there's still a debate in the science about whether that will actually prove to be helpful. But I think potentially could be. So, yeah, it's one of the things that I tend to do is I look at the countries that have been successful against coronavirus, and then I think, well, what can we implement here in the U.S.? And China's been extremely successful, and they do utilize fever screenings. And so, in terms of cost and invasiveness, to weigh that up, it could potentially be useful.
Thank you. I've got a couple more sort of macro questions to ask you. Before I ask them though, Norma, we have a question about when this recording will be available. Can you give us a quick idea on that?
It takes just a little bit for things to process, but I am going to, as soon as physically possible, I'm going to be uploading it to YouTube, and then I'll pop it out to Facebook. And so by the end of today, it just depends upon how long it takes for things to process. An hour-long video is longer than our 9 at 9s in the morning, which take a good 15 minutes.
Yeah. And I want to thank everyone for being patient. I've gone through the chat in different order than normal because I've been trying to, some of you have asked the same questions, but in different ways. And I've been trying to honor that without trying to go through our time effectively. So, so the couple of the questions, I've got to go back up in the chat. Two important questions. First, a childcare question. We have lots of small children in some of our churches. Is there even any way to keep our churches remotely clean environments, right? Many of us have had small children. We have seen your coworkers today. We love having small children running around our churches. Is this even, how can we do daycares, nursery, Sunday school? When will that be safe for our members?
So when you look at the evidence base behind social distancing, we know that it works on a mechanistic level, right? Just because if you're not near the virus, if you don't breathe into your body, you can't get it. So that's the scientific proof that works. From observational studies, we've never had so big social distancing measures put in place before, and so it'll be 5 years from now when we look back on and the U.S. response, given that it's been it's varied quite significantly by state. So that we'll get a better idea of what social distancing did to the epidemic and how it worked. School closures are very well studied, and they are very well known that they work extremely well. So we know from just the holiday season, if you look at transmission dynamics of influenza with routine holidays or Christmas or Thanksgiving. If you look at unexpected closures due to teacher strikes or inclement weathers, all these studies, it's 10 to 15 different studies have all shown that closing schools reduces transmission of respiratory virus. Because of that, I'm concerned that my kids are never going to go back to school. I'm preparing for homeschool in the fall, and I wish that they would go back to school. A couple aspects of coronavirus are particularly important here. Kids don't appear to get they don't appear to die. They don't appear to get hospitalized from this. Doesn't look like they get severe disease. That said, we don't know the long-term consequences, and there's some worrying case reports of lung lesions in children with coronavirus that could potentially develop into asthma. And so all the consequences of getting this virus, all viruses have consequences, but this one, we don't know yet. Find that out over the next few years. So although kids don't typically get hospitalized and don't typically die, I wouldn't necessarily say that they are safe from coronavirus. I'm still, slightly about them getting it. It also appears that kids contract coronavirus at similar levels to adults and then transmit it also. So they can act as little disease vectors where they may not know they're sick. They may not come down with symptoms, but they have the virus. And then childcare is definitely an intimate contact environment. And so that is definitely where kids are going to be exchanging pathogens, whatever it may be. And people that have put kids in daycare or preschool know as soon as they go off that they're just going to have about 2 or 3 months worth of illness before they acclimatize to the pathogens that are present in that group. And once they clear those, then they're usually fine for it. And so coronavirus would spread. And so I would think that childcare would be a high risk activity.
So, when you said that about the fall, every parent or grandparent on this call just died a little bit inside.
Yeah.
I'm
sorry.
Yeah.
Yeah. I'm sorry.
Yeah. No,
I think they'll open. I think the schools will try to open. But I don't know, unless if you can get it contained within a county, right? If you can get it What I would have liked to see done, the leadership is basically, and it's probably not feasible given the American freedom, is basically just lock down every single county, make every county an island, no travel in or out, and then progressively, as you establish no transmission within counties, you just expand those borders and start taking away the walls and free people. But I think based on the American paradigm of freedom, we're going to be in this for a long fight.
Friends, I'm aware that there are a few more messages coming in, but we are also coming close to our hour, and I'd like to ask for sure this one chat message. What 3 things, Dr. Larsen, can we be sharing with our church communities? Like, what message should we be sending them that is both a faith-filled message, but also and also something that is science-based, that will enable, well, I'll just leave it at that. What is something that is helpful, that even beyond everything you said today, of course, it's been terribly helpful, but like, what should we know coming out of this that you want us to know?
So one of the big things is that the big thing that I think the influence that faith leaders can have is to encourage cooperation, cooperation with contact tracing and with isolation. And that intervention is the key to freedom, in my opinion, to broad freedom. You know, the alternative is to just let this thing run its course, and that's not what I want to do. And so the contact tracing system is the solution, and the vaccine will come or over time. And so the more buy-in from the community around contact tracing would be the better. And so if you can encourage people to seek treatment when they have a fever, you know, try to get a coronavirus test. Try to isolate yourself if you're sick, and then comply with the county health when they do the contact tracing. That's a big one. The second one would be that masks are no substitute for social distancing. So masks are not 100% effective at filtering particles of virus. And there's a hope that they work, but there's not scientific conclusive evidence that they do work. And so the weight of the evidence suggests they will, but it's not Loctite. And certainly if people are not taking the social distancing seriously, then masks are not a substitute. The third, I guess, is a bit of hope. You know, humanity has been through this every 10 to 20 years since the fall. Right, since all that, so this is normal. The last 100 years is abnormal, right? So the last 100 years, especially the last 50 years, with the control of infectious disease in the United States, is a very bizarre development in the history of humankind. And so before that, you have 10 to 20 year epidemics just sweeping across the world, over and over and over again. Whether it's measles, whether it's smallpox, whether it's influenza, now coronavirus. You know, this is what our cultures and our species have adapted to these things, and so it's a reminder of what's out there. And so I take comfort from the past, knowing that this is not an existential threat. This is not the end of humanity or society, and I put faith in the future that we will get through it. So those are three things.
That's just so lovely and helpful. I want to ask one more question, and then I think we'll be finished. Specifically for our rostered ministers on this call who are going to struggle with when they are allowed to reopen their doors, right? When the governor or their county executive says, okay, you can do this now at your discretion, probably is what's going to happen. What should they be looking for to know when to do that? And what can they say to their councils or their congregations if they have underlying conditions themselves and are not comfortable doing that right away?
I'm a big believer in honesty on the second part. And just to be honest with people and to explain the facts and say a simple, I'm not comfortable with the amount of risk and I'm sorry. And then to potentially give alternative places of worship that could fill in. On the first, you know, I fluctuate between life must go on and let's shut everything down to save everybody's life. And the life must go on with caveats around, you know, like we can change our lives to try to save as many as we can. I would just take cues from the local health department and take cues from the statistics. I think if you try to play the game of is it safe now, is it not? Is it safe to open, is it not? It's a probabilities, it's a throw of the dice, right? And instead I would look at what the county health department is suggesting and take cues from them. They will understand what the transmission dynamics are like within the county. They'll understand the risk of importation. and the county health, I would take guidance from county health in that regard. And I think the governor's plan, the state plan to reopen is solid, right? So I'm impressed with that, and hopefully we can strengthen it over the next few months and give you all some more confidence in the absence of transmission. That's the goal of the wastewater stuff. And then the contact tracing should hopefully give people confidence. But so yeah, write your legislatures that you want wastewater surveillance soon. I don't know if I can promise that it'll work all completely, but hopeful. But yeah, so I would take advice from the county health department.
Thank you. And Dr. Larsen, I don't want to put you on the spot, but if I've missed any outstanding questions in the chat from our rostered ministers, could we send them to you via email for a quick response from you? Would you be all right with that if the bishop?
Yeah. And I don't have my next meeting's not till 2:30.
Oh.
If people still have questions, and I can never do anything well in a half hour.
I think perhaps the only one that I missed was because I'm aware that people will have to go on to other meetings, but I think I missed a couple up here about maybe giving communion individually. Just sort of very specific questions about that. Like, could you see almost the Catholic way of doing confession individually? Could you see, would that be a safer way of giving communion? Like a home visit, Pastor Tara says, but at church. You know, if the pastor is washing their hands and giving communion, etc.
Yeah. I think that would be an alternative that could be played out. I know that my congregation stopped all the home visits right now because the fear is that the person visiting the house is bringing the virus with them. And then there's a secondary fear of the person, and I say that's the primary fear because that's the spreading event, right? So they're spreading it to house after house after house after house. The secondary fear is that the person picks up the virus from that. So I would, if you could space it out, you know, in terms of timing and days, and follow good infection protocols, and, you know, use your mask, wash your hands thoroughly, all those things, then I think that would be safer than bringing everybody to a centralized location. So okay. One of the reasons that, you know, the testing they do at a drive-through is because people are suspected to be sick, so they don't want people going to one house where there's probably infection and taking that to another house, right? So that's why they bring everybody that's sick into a drive-through testing center. But from a healthy population perspective, bringing everybody that, and maybe one or two is sick into that central location, that's not the best approach to keep everybody healthy. So it's a better approach for diagnostics, because they're sick, but not for keeping people healthy.
We also have a question, is humming safer than singing, or is speaking better than singing?
I'm probably not the expert to answer this one. My guess would be yes, that the louder you sing and the more you open your mouth, with more force that you expel that you resonate your voice, that you'd have more transmission, would be my guess, but I'm probably not the expert to answer that one.
What about having communion on very large trays, a wafer and an individual cup spaced apart, and people can come up and take one while keeping a safe distance from each other?
Yeah, so you don't want, so it's like, you think through, like, what are the scenarios where virus could get transferred onto those surfaces? And so you have the scenario where the pastor has the virus, and then it transfers onto their hands or through their mask onto what's in front of them. You have a scenario where somebody in the congregation has the virus, and then it transfers onto their hands, and so then onto the surfaces they touch. And so the spacing of the cups probably would not be an issue unless your congregation is touching multiple cups, if that makes sense. And so, I would consider that to be a low priority. But the but the individual cups will be high priority.
Okay. What other perhaps new basic needs rise to the top when a society goes through a pandemic? I'm suspecting, Rahel, that this is faith-based needs. If you want to unmute and tell us.
Not necessarily faith-based, actually.
Okay.
Especially from an epidemiologist's perspective, what needs do you see sort of spike up? And I obviously don't mean the immediate health care, but as you look through population, are there market shifts in needs?
Yeah, I think the one that I've observed first and foremost is economic. And I think that's pretty apparent in the unemployment statistics, and so you're just going to have everything to do with unemployment. And so with pandemics come recessions and even depressions. And so that's hard. That'll hit really hard, is the economic fallout from this. And I don't see that as a result of social distancing. You know, if you look at the data on restaurant attendance, it had fallen off a cliff in February and March. And so that's before social distancing came into effect. And so I would look at economics. Do they have enough food? The food supply in the country looks robust. And I think in the state is robust. And we live in a pretty bountiful area in terms of farms and agriculture here in upstate New York. So that's one. The other aspect that I would look at is mental and social health. And so, you know, the opioid epidemic didn't go away. That's still there. And that's a symptom of the mental health. And I think the social isolation is just going to exacerbate those challenges. And so the more that we can try to stay connected with people on an individual and emotional level, the better off we'll be to get through this. So those are the two big ones that I see. Another one that I've read about is the abuse, the domestic violence, also increases with stay-at-home orders. So that's a worrying trend. And so if you have members in your congregation in those situations, those are people to reach out to specifically, I would think.
Thank you. Should pastors wear masks during worship? And are there any speaking or projecting dangers? I'm guessing that's a vocal question, right, for the voice. But should that just be an assumption that the leader should be wearing a mask? Or if the leader is 30 feet away from everyone else, would they be safe taking their mask off, especially if there was a microphone?
Yeah, I would think, it's a function of distance. It's pretty hard to speak through a mask, so you could erect also like a pulpit shield, like a plexiglass box around the microphone or something to block particles from going. But yeah, you don't want to be spraying the congregation with virus, and so a mask would reduce that. And then there's some physical barriers that could help to reduce that as well, depending on the situation. And then distance is helpful. But yeah.
And that also goes to the next question, which is how much cleaning, if we had, let's say, two services, an 8:30 service and an 11 o'clock service, how much cleaning would have to be done? Like, does the entire building need to be emptied so that every chair can be wiped down, so that the entire bathroom can be cleaned? What needs to happen if you have more than one service on a Sunday?
So I would think about this through the function of the churches are reopened, so that, to me, that suggests that the transmission is under control in the county. They're controlling transmission relatively well. That's That's the point that I would think that the churches can reopen. And I'm hopeful that we can get there. Now, with that low transmission, I would probably space out the congregations a little bit more beyond 8:30, 11 o'clock to give time for some decontamination. And that would include all doorknobs, certainly all handrails, banisters, places that hands are going to touch. Now, places that are sat upon, surfaces that are sat upon, would be less prone to having a virus. But you definitely want to wipe down all the areas that hands would touch. So yeah, and there's likely, my hope is the CDC would advise on this, would give thorough disinfection protocols for churches. I think that would make a lot of sense if the CDC did that. And so these are, as a group, as your the Synod, the Upstate New York Synod, if you write them and ask them, say we want this, then they have more expertise in this area than I would in the disinfection protocols, and they might be able to offer some guidelines. But this is the function of the CDC when it is running well. They've been a little bit absent during this pandemic, frustratingly. And but I would write them as a group and say, we want guidelines with this specific scenario in mind. Can you give us disinfectant protocols that we should follow and adhere to? In my personal opinion, and this is not my area of expertise, is every single surface that would touch hands should be disinfected between congregations. But then personally, like, I don't even want my parents to go to church until after there's a vaccine. So I could give you an idea of me personally. Like, I'll go back to church potentially, maybe, I don't know. But my parents, like, I don't want them to go back to church until they have a vaccine. So it's just a risky environment for transmission.
Yep. Okay, I think we're to the last question. How many people per square footage would you recommend? Like, this is a very specific question. Can you, yeah.
Yeah, it's too hard for me to answer. That's too hard. The more people you have, so any infectious dynamic within a building is going to be a function of the space, the interactions between the people, the air circulation, a lot of factors, and so it's just too hard to answer that question. So fewer is better is the rule. Fewer people is better.
Okay, I think I've gotten everybody in the chat. If I didn't, just go in the chat really fast and say, Julie, you missed me in the chat. And I'll grab your question. Oh, wait, Brenda, just go ahead and ask it. Just unmute yourself and ask it. Thank you. My apologies.
No, it's fine. I know we don't have time to go into specific testing versus antibody versus active testing and things like that, but you had mentioned clergy, deacons, and other worship leaders getting tested. Just because I test negative today doesn't mean I'm going to be positive tomorrow. Do you recommend frequent testing for clergy, or because I get the understanding maybe from people that might not know the way that testing happens, that just because I'm tested negative means I'm good to go. And I know that that's not the case. So what do you recommend about that?
Yeah, so in terms of testing people to see if they are infected without symptoms, it takes a few days before, so you have your transmission event, and then in order for the test to actually register a positive, they got to detect that viral RNA up in your sputum, and maybe they'll get to the point where we have saliva. There's a few saliva tests being developed, right? So the viral RNA has to replicate within your body sufficiently such that it's in your saliva or in your sputum, which is in the nasal cavity, right? And that takes a few days. And so you have transmission event on day 0, and then you're going to test positive maybe day 2, 3, or 4, right? And that's about the time that you start to shed virus. When you're shedding virus, you'll test positive. And when you shed virus, that means that you're putting virus out in the environment and making other people sick. And that precedes when you yourself get sick. So you start shedding virus before you yourself get sick. So what a routine testing would do of essential workers and clergy, what that would do is try to catch those people who have an active infection who are not yet symptomatic, or who have an active infection and are asymptomatic. And so from a clergy perspective, I would think that you'd want to, if your major engagements with the public are on Sundays, I would test every Thursday, right? And so that gives enough time for that virus to come through, and you're going to test positive if you picked it up on Sunday, and it's enough time to prevent you from doing your services on that next Sunday. Now, just because you tested negative on Thursday, that doesn't mean that you're uninfected in the future. You're just not infected at that point on Thursday. And so you do need that repeated testing. And yes, so it's a good point brought up there on that. But Thursday, maybe Friday, depending on when you do your services.
Thank you, Brenda. Sorry about that. All right. Bishop, I think we've come to the end of our chat.
Okay, well, thank you for leading us in that, Julie. You did a great job. Appreciate that. Dr. Larsen, I want to say thank you. This was a sobering hour and 20 minutes, but helpful in putting before us what we need to know and need to do. As challenging as that's going to be for us who are people-pleasing people and like to be with people, the road ahead looks to be a long one. And that's frustrating, I think, for a lot of us, but we also know that what we need to do is not follow our feelings, but follow the facts that come out of the CDC and our county health departments, and make sure that we pay good attention to them and follow them along the way, whatever that may mean for us. So thank you for your time with us, all the work that you've done. Just a small point of information for you. The Lutheran Church in Zambia and Zimbabwe are companion churches to the Upstate New York Synod. So I was supposed to be in Zambia actually today, visiting with some colleagues there, and then Zimbabwe after some time in Johannesburg for a consultation meeting. So I found it interesting that you had the Zambia connection, and it's sort of like 6 degrees of separation. But thanks for all of your good work. I really appreciate your time with us, and pray that as you continue to work, you find ways to help us and others move forward in the midst of this pandemic with some hope, which you've offered. So thank you very much.
Thank you, Bishop, and thanks everybody. And best of luck.
You were awesome. Thanks, Dr. Larsen.